it will decrease. So it's at the end of contraction. So once you have had a period, so when you start exercise, blood flow increases, and then it will it will remain very high. It will remain high during exercise, and once you stop exercise, it will continue to be very high for a few more seconds, and then slowly start returning to normal over a period of minutes. Now, if you look at the muscle tissue, during the contractile phase of it, the blood flow is reduced because the vessels are constricted. And when it's relaxed, then of course the flow increases. So you get to a state where the skeletal muscles can go into tetany. And if they do go into tetany, then the blood vessels supplying those particular muscles which are in tetany will have virtually zero blood flow, right? So that will cause lack of nutrients coming in, and the tetanic contraction, therefore, will weaken over a short period of time, which because there is lack of nutrients to maintain the contractile tissue. So let's look at what happens to the capillary bed in muscles during exercise. So during rest, there is hardly any need for them to be open. So basically, there's very little flow, or even you can say no flow. But when there is exercise, these capillary beds open up, and during strenuous exercise, all the capillary beds are open. Why is that? Again, by opening up the capillary beds, the amount of distance the oxygen and the nutrients which diffuses out of the capillaries must travel to meet the destination then becomes progressively lesser. This also in turn increases by opening up of the capillary beds. You will open up the surface area. You will increase the surface area available for diffusion of nutrients and oxygen. Therefore, again, it will help the muscles to continue to contract during exercise with the rapid delivery of nutrients and oxygen. So you can actually increase the capillary surface area by 2 to 3 fold during exercise. Now, how do you actually control? How is actually the blood flow control? So, what are the factors? First thing is when you have activity or in skeletal muscles, there is reduction in the oxygen within the muscles. So oxygen reduction enhances flow mainly through a couple of things. So the reduction in oxygen causes direct chemical action on arterioles to dilate. So basically, buildup of carbon dioxide, lactic acid, ATP, and potassium will directly act on the arterioles to dilate. Then the reduction in PO2 will also cause will also directly act because arteriolar walls to maintain its level of vasoconstriction needs the smooth muscles to be contracted. But if the reduction in oxygen, you cannot maintain the contraction, so that can also vasodilate, and also the oxygen stimulates release of vasodilator substance, adenosine. And adenosine acts directly again on the arterial walls. Next, you have the nervous control over muscle blood flow. So let's have a look how our central nervous system will work. So when in exercise, you have increased sympathetic discharge, and the sympathetic system will have vasoconstrictor nerves as well as vasodilator nerves. So where are these So if you revise it a little bit. Sympathetic vasoconstricted nerves will release NORAD or norepinephrine and reduce blood flow by up to 50%. Right? This is basically done to increase your blood pressure. Then through the sympathetic nervous system action through the adrenal glands, which again secretes. So when there's sympathetic nervous system activity, adrenal glands get involved, and it gives no, it reduces NORAD, but it releases more adrenaline. 80% adrenaline, 20% noradrenaline. Now, NORAD has only vasoconstrictor effects, but adrenaline has a slight vasodilator effect through its beta adrenergic receptors in the vessels. So, through that adrenaline effect of beta 1 effect to the skeletal muscle arterioles, there is vasodilatation as well. Right. Now, let us have a look at what are the circulatory readjustments that occur during exercise. There are three major systems we have to look at. So we have increased cardiac output, we have increasing in systemic blood pressure, and we have sympathetic nervous system activation. Right. So let's see how about the sympathetic nervous system. At the onset of exercise, you have your vasomotor center, which gets activated, and your parasympathetic nervous system is attenuated. So basically, you have the balance of sympathetic to parasympathetic nervous system is now heavily tilted towards the sympathetic nervous system. So the sympathetic nervous system activation will result in what? Increased heart rate, increased contractility of the heart, and vasoconstriction of most of the arteries. But remember, this vasoconstriction results in non-muscular area blood flow to be reduced. Okay, but it spares the brain and the heart. So the coronary and the cerebral blood systems are spared. In addition, remember, blood flow to the muscles is increased. So the vasoconstricted tone is not there in arterioles. This is mainly through the adrenaline effect, beta 1 effect, which is there. So what happens? So again, if you think about it, the surge of sympathetic nervous system resulting constriction of arterioles to non-muscular areas, dilation of the skeletal muscle arterioles, and sparing of the coronary and the cerebral systems. Then on the venous side of it, nearly all the veins are constricted. Therefore, you increase forward flow. So your venous return is therefore increased because your mean systemic filling pressures are increased, and therefore increasing venous return means you increase your cardiac output as well. Right. The second mechanism is by increasing arterial pressure. So how is this arterial pressure increased? Like I said, there is, other than the muscular blood vessels, everything else is vasoconstricted, sparing the coronary and the cerebral. So that will increase the systemic vascular resistance, which will then cause you increased blood pressure. Then increased contractility of the heart increases blood pressure. Increasing heart rate will increase blood pressure. And increased mean systemic filling pressure will also increase blood pressure. So on average, an exercising individuals, blood pressure, mean arterial pressure can be increased by from anywhere from between 20 millimeters of mercury to 80 millimeters of mercury. So quite a large rise can occur through exercise. So if you look at tension exercise, tension-based exercise versus what do you call dynamic exercise or whole body exercise, the MAP is more increased in tension exercises. Now, what is that? Well, now, an example of a tension exercise is standing on a ladder and nailing with a hammer on the ceiling. So you can understand that exercise to you, to us, may seem like only few muscles are working, but you are under a lot of tension. Why? You need to maintain your balance because you're off the ground, and not only that, you have to maintain a very what do you call complex activity needs to take place. So therefore, your mean arterial pressure may go as high as 170. But usually in dynamic exercises or massive hold exercises like running or swimming, usually the mean arterial pressure does not rise by that much. It rises by about 20 to 40 millimeters of mercury, and that is how it's kept. Now, if you look now, why do we need to increase the pressure? When the pressure increases, actually, the blood flow to the muscles increase by nearly 20 times. Now, why do I say this? I say this is if you keep the blood pressure at the same level and do maximal exercises, then the blood flow to the musculature or the skeletal muscles will only increase by 8 times, eightfold. It is increased up to more than 20 times. I said 25 to 50 times you can increase. That increment comes from increasing the arterial blood. Why do you need this increased pressure? Number one, you to push a greater volume of blood through the vasculature, you need more pressure. And the extra pressure you generate will cause vasodilatation, which will cause the vessel walls to stretch and release more vasodilators. So all those will only combine to give you an increment in your blood flow by 25 to 50 times by this increment in the blood pressure. And the third method is by increasing cardiac output. Now, cardiac output increase is proportional to the degree of exercise. With heavy exercise or strenuous exercise, the cardiac output increases much higher. So you can all remember this graph. This is the venous return versus cardiac output. This is the usual graph. Right. So this is the usual one. This is the cardiac output versus venous return graph. So from this point, actually to this point, you can increase your cardiac output and your venous with heavy exercise. So you can see from 5 liters per minute, it can go up to somewhere around 20-25 liters per minute. This is done almost entirely from sympathetic circulation. So cardiac output, if you remember the definition of cardiac output, is the amount of blood volume injected by a ventricle into either the pulmonary or the systemic circulation. And that can be calculated based on the stroke volume and heart rate. And by sympathetic stimulation, you will increase your heart rate to around 170, 190, and the contractility you double. So by doing that, even in an untrained person, you can increase cardiac output 2.5 times to 4 times in an untrained run. In a trained person, especially the marathon runners who have dilated hearts, they are conditioned. They have larger stroke volumes and larger hearts. They can even increase their cardiac output up to 7 times. The sympathetic stimulation also changes your venous return curve. It will shift it up as well as to the right. So from normal mean systemic feeding pressure of about 7 millimeters mercury, it can rise to about 30. Only rise about 1.5 millimeters of mercury. In actual fact, larger people with larger hearts, like in the marathon runners, they actually it falls below normal. But this can be only tolerated as long as the heart is in good condition. If you have a weak heart, then the increased venous return cannot be tolerated by the heart and is going to fail. Therefore, your right atrial pressure, if your heart is failing, your RAP will rise. And therefore, even with moderate exercise, your heart may fail and your right atrial pressure may increase, which then becomes dangerous. So let us see a graphical interpretation. Okay. So this is the heart rate versus exercise. So we can see the heart rate increases virtually linearly from rest to light exercise to medium exercise to heavy exercise. Stroke volume rapidly increases to light exercise, then increases a little bit more up to medium exercise, and then it's virtually plateaus off. And actually, with heavy exercises, with very high heart rates, may actually start dropping down. It's because of reduced diastolic filling time. And if you look at the blood pressure, your systemic blood pressure or systolic blood pressure marginally increases with light exercise, increases a little bit more with medium exercise, and then further increases with heavy exercise. But your diastolic blood pressure, which increases marginally during light exercise and marginally to medium exercise, then starts dropping, plateaus off and starts dropping with heavy exercise. Therefore, your pulse pressure increases with increasing severity of exercise, but your mean arterial pressure continues to rise very slowly with increasing exercise. Let us have a look at how the respiration changes. So if you look at your PaO2 or partial pressure oxygen, it usually starts dropping only with very heavy exercise. Otherwise, your arterial oxygen saturation is usually maintained normal. But your mixed venous oxygen is dropping. Why? There is more extraction taking place within your muscle layer. So more extraction, and virtually you're at about 20 millimeters of mercury active exercise. Your carbon dioxide generation will be greater. Therefore, there's a slight increase with increasing exercise levels. And then it starts deteriorating, rapidly falling off. Why? It can't increase anymore because now you have gone past the anaerobic threshold. And then now you are now not generating carbon dioxide because now your aerobic threshold has reached and therefore you are not generating any more carbon dioxide. And if you look at your ventilation gradually goes up from light to medium, and then towards the end of heavy exercise, it starts increasing some more at a rapider pace. But in general, it usually goes up lean. Right. So let us now look at in depth at what the respiratory responses are. So your tidal volume and your respiratory rate usually increase in proportion to increase demand of your oxygen and excretion of your carbon dioxide. So the increase in minute volume is basically controlled by the motor cortex because there's neural input into the infrared center. There's neural input to the information from the motor cortex. So when you are starting to exercise, the motor cortex informs your respiratory center to breathe a little faster and in deeper. And then you have proprioceptive input from your muscles. So therefore, your tidal volume and your respiratory rate will increase, thereby increasing the minute volume. And the increase is sustained by increased sensitivity of the carotid bodies, which responds or which controls the respiration through its responses to hypoxia, hypercarbia, and stress. As you can remember, there's a disproportionate increase in very high levels of exercise of the minute volume. This is basically because when you have breached your anaerobic threshold, you now have lactic acid accumulate, which acts as an additional stimulation to the carotid bodies, right? But your carbon dioxide production is no longer that great, or it has plateaued because now you have having anaerobic metabolism occur. So your minute volume is increasing, your carbon dioxide production has plateaued, and therefore your PaCO2 will now start dipping. So there is a level at which you have maximal oxygen consumption, and that is called anaerobic threshold. This is the point muscle metabolism, excuse me, all right, sorry. Okay, so anaerobic threshold is the point at which your muscle metabolism will switch from aerobic to anaerobic, and it's around 60% of maximum exercise level. Right. Okay, so I think we have gone through all of this. So I'll just read it through. So initially ventilation rises in proportion to oxygen consumption and CO2 production, and therefore PaO2 and PaCO2 are close to normal, which we discussed. And then at maximal exercise intensity, we have ventilation rising faster because now there's anaerobic metabolism occurring, and there is greater stimulation of the carotid bodies by the lactic acid, and it reaches, but the oxygen has plateaued, and actually your PaCO2 production also has plateaued, but because your minute ventilation has increased, your PaCO2 starts falling, and at the start of exercise, your heart rate actually starts beating faster because your sympathetic nervous system is activated, uh, and your parasympathetic nervous system is now inhibited, and then you will simply start increasing heart rate over 5 to 10 minutes to a steady level. Then at the end of exercise, heart rate and volume falls sharply at first, and then later on more slowly. During exercise, the barometric reflex is reset and it operates over a higher range of blood pressures. That is why your map is now 20 to 40 higher in whole body exercise or about 70 to 80 in tension exercises. Uh, there's a compensatory fall in the peripheral vascular resistance due to the metabolic vasodilatation in exercising muscles. And in severe muscles, there's an increase in activity. And the chemoreceptor reflexes are also reset with a greater response to changes in oxygen saturation. Then the other things which happen. So those are the cardiorespiratory changes in exercises. Then if you look at the other systems, you have a core body temperature rising about 1 degree in moderate exercises. Your skin blood flow increases to get rid of, therefore, to get rid of the heat. You have vasodilatation of your skin, and your skin blood vessels increase, skin blood flow increases. Then you have increased, so you have increased heat loss from there, and then you start sweating more profoundly, which will help you to control your body temperature by increasing heat loss by evaporation of the sweat, as well as you lose a lot of water from the respiratory tract through evaporation as well. In sustained heavy exercises, the core temperature will rise some more because with more intense constriction, and actually about 15% of the plasma volume can shift to the interstitial space of the muscles. So there can be some muscle edema occurring, and loss of water and sodium is there in sweat, and loss of potassium in the interstitium. So you can have dehydration, hyponatremia, as well as hypokalemia. With training, you can do anaerobic training for short-term power. So basically what happens is when you're doing these 100-meter sprints and everything, they do not breathe during their sprint. So they do what is called anaerobic training, where you will, the end product is left ventricular hypertrophy with increased blood pressure. And if you are doing longer sprints or like things like marathons and stuff like that, you do what is called aerobic or endurance training. And that's basically you increase the maximum oxygen consumption, and you increase your cardiac output by increasing stroke volume. This is mainly done by increasing your left ventricular volume and circulating blood volume. And at cardiac output at rest is normal, but heart rate may fall because there's increased stroke volume. So that is why in well-trained athletes you see bradycardias. Then another few things for you to keep in mind. Uh, the terms isometric exercise and isotonic or dynamic exercises. Sorry about that. So isometric exercises are the exercises which lead you to cause sustained compression of blood vessels in muscles, right? So therefore, there is reduction in blood flow with increasing total peripheral vascular resistance. There's increased sympathetic activity, and therefore there is increased blood pressure, increased heart rate, and increased cardiac output. Whereas in isotonic or dynamic exercise, there is a fall in diastolic blood pressure because there is peripheral vasodilatation, and there's a greater increase in the heart rate. Okay, that's about knocks off my exercise component of it. Any questions? Okay, there does not seem to be any questions. So I will now move on to the second component, hemorrhage control, the integrated cardiovascular response in hemorrhage. Okay, right. We'll get back to this at the end of it, but this is the entirety of what I'm trying to teach you. Let's see whether we can get through this. Right. Hemorrhage leads to what is called hypovolemic shock. So when you're talking about shock, any shock, there are three basic stages. So there is the non-progressive stage, or the which is also known as a compensated stage, a progressive stage, and an irreversible stage. So what the irreversible stage means, whatever you do, whatever therapy which is available, whatever you do, you cannot save the person's life. Whereas in a non-progressive or compensated stage, you need not do anything for the patient to survive. So the patient will survive without any help. Okay. But in the progressive stage, you need to intervene, because unless you intervene, there will be some form of, excuse me, so sorry. So at a the in the progressive stage, without doing therapy, you cannot prevent death. So it is for this progressive stage that you need to intervene and treat for the patient, your patient to survive. Right. So what is the effect of hemorrhage and blood pressure? So you can have a look. So look at this. When you are removing percentage of blood pressure, so if you look at 10%, 10 to 15% removal of your, so okay, let's do it this way. Let's look at the changes in artery. You can see that the arterial pressure is virtually zero at about 45% of your blood loss, around 40%. So basically, you have dropped your blood pressures by about 50% at about 35% of loss of blood, your blood volume. But your arterial pressure will continue to remain the same until about 20% of your blood loss is there. But your arterial pressure, your compensatory system seems to fail beyond around 20% blood volume loss. So arterial pressure starts dropping dramatically until some around here, when you seem to have been having a final, the body seems to be putting up a final effort trying to preserve your pressures, even though it's 50% of your normal, and then it will simply go down. So you can see, if you do not recognize this part and attempt some therapy, you are in deep trouble. And you probably shouldn't be waiting until you're somewhere here, but start somewhere here. So the important thing for you is to recognize when you're here. Now your arterial pressure is maintained, but your cardiac output is falling when you have lost about 10% of your blood. So this seems to be falling at a more, what do you say, like a more linear form, with the steepness increasing when you have lost around 35% of your blood volume. So from about 10% of your blood volume loss, your cardiac output starts to fall. and it falls more rapidly after about the 35th, after about 35% of the blood volume is fallen. And corresponding to this particular last ditch stand, there seems to be a little bit of attempt at stabilizing cardiac output also. But the rapidity of the last part is quite obvious for anyone to see. Okay. So from 0 to around 35% or 40% blood volume drops it from 50% to 0%. Now, this is important for all of you to understand, because unless you recognize these patients early, attempting intervention here is useless, right? And if you do not look for the clues required, you will miss this part. Because, like I said, here pressure is normal, right? So you are dead by loss of, when you lose 45% of your total blood volume, and you can, and people can say you are absolutely normal with 20% blood volume loss. So if you have ongoing losses, look at the rapidity of your of death from a perceived. I hope that is clear to all of you. When you miss this is when you get this so-called sudden cardiac arrest. So as you can see, the first to start dropping is your cardiac output. Next is the blood pressure. And like I explained, both fall to 0 at about 40 to 45% total blood volume. I recently had a registrar who tried to teach me that blood transfusions, you can withhold blood transfusion only 60% of a total blood volume is required. So I said I will be lucky to avoid her when she's a consultant. Right. So what are these compensatory mechanisms which help you to maintain normal or near normal levels of your cardiac output and blood pressure? So initially, the baroreceptors and other stretch receptors will get less stretched, and therefore it will trigger sympathetic nervous system stimulation, which will then result in all the vasoconstrictors being activated, increasing your systemic or peripheral vascular resistance to maintain adequate adequate venous pressure despite your total blood volume being diminished. Then your heart rate and your contractility increased, thereby trying to maintain your blood pressure. If you did not have the sympathetic nervous system working, 15 to 20% of your loss of blood volume will cause death. It is purely because of your sympathetic nervous system that you will not die at 20% blood loss. You will now die only at about 40% blood loss. But if you have lost your sympathetic system, then you are dead when you have lost 1/6 to 1/5 of your total blood. The sympathetic nervous system mainly acts on your pressure, not your cardiac output. Because if you can remember, cardiac output equals stroke volume into heart rate. Your blood pressure equals cardiac output into SVR. Right? Now your your stroke volume is reduced, heart rate is increased, and your systemic vascular resistance is increased much more. So therefore, you can see, even though there's a small reduction in your cardiac output, it is compensated by a greater increase in systemic vascular resistance, which will maintain your blood pressure. Now, I talked about the second plateau, which I showed you at about 50% of your cardiac output and your blood pressure. So that's called the second plateau, which occurs at about 50 millimeters mercury pressure. And this is basically because now your brain is not being perfused. So it's called the central nervous system ischemic response. The central nervous system ischemic response releaser floods the body with large amounts of catecholamines, basically induced by hypoxia and hypercarbia of the brain. And it is called the last ditch stand. Again, why protect blood pressure over cardiac output? We know we need to protect the heart and the brain. So whatever little you have, you now push towards the heart and the brain to keep it from failing. Also remember, the coronary and the cerebral blood flow does not have a large impact by the sympathetic nervous system. It is usually dependent on local autoregulation. And as long as your systolic is around 70 or above, your brain and your heart is usually perfused. As a cardiac anesthetist, I recently, about 3 or 4 months ago, I had a patient with a aortic dissection, emergency aortic dissection. And so the dissection was repaired and we came off the cardiopulmonary bypass machine. Everything seems to be okay. And suddenly the patient crashed. And with maximal inotropes, we were able to maintain only about systolic 65. So we were very upset because it was long surgery and we were trying very hard. It was a young patient, around 45, 50 years, had 2 or 3 young children, I can't remember. I remember there was one girl about 8 or 10 years old who was outside waiting for the father to, recover. And we were also under a lot of tension and we were very upset. But even because we couldn't increase, so we were basically on the verge of giving up. When after about 3 hours with a systolic of 65, he started recovering. And once he recovered, actually, he went home. He was there with us in the ICU for about 3 weeks, but he went home and he had zero neurological damage. So we were very happy. So this proves that a systolic pressure of around 70 is enough to protect your brain and your heart. Now, again, let's have a look at what happens. Now, what this graph I have put, this is from Guyton. Now, this shows what experiment they have done. So, what have they done? Look, what have they? They have taken some dogs and they have bled volumes of blood out to see what happens. So, you can see that you start bleeding a dog up and you drop your pressures to about 15%. And then you stop. This dog, over a matter of time, recovers and will survive. If you drop to 30%, say 40%, say. But moment you breach the 40%, which is seen in dog number 4, 5, and 6, death ensues. Look at this difference between 4 and 5. In the 4 and 5, there's only a very small, minute difference about the amount of blood removed. Of course, greater than 40%. But look at the response. Both respond virtually similarly, but both of them die. So if you look at 3 and 4 also, very small change. The fourth one, they have taken about 50% of their blood volume. And the fourth one, about 55%. So a few ml more can result in death. The more the volume loss during acute hemorrhage, the shorter the person will live. See, if you have lost 80% of your blood volume, you are dead in 3 hours. About 60% of loss in about 5 minutes. About 40, so 55% loss in about 6 hours. But a few ml can result change, can tip you from being from 3 or being alive to being dead. Please understand this critical amount. So what are the compensatory mechanisms? We have discussed, I'm just summarizing, the sympathetic nervous system by the baroreceptor reflex, then the central nervous system ischemic response, again sympathetic, then reverse stress relaxation of the circulatory system. Now what is this? Reverse stress relaxation of the circulatory system means the inherent ability of the blood vessels to constrict around the given blood volume. In other words, these are not like your S-non or iron pipes. It will, if there is a blood loss, you will not have a what do you call, emptiness, empty space inside the vessel. The vasculature will constrict around your blood volume so that the blood volume is it's the same. This is called the reverse stress relaxation of the circulatory system. And then the other one is, which we didn't talk about, is the RAS system, where you have increased renin secretion due to drop in the blood flow to the kidney, which will then activate the renin angiotensin system, the RAS. No, I have made a mistake there. It's RAAS, renin angiotensin aldosterone system, which will, sorry, call. Right. Sorry. So the renin-angiotensin administration system, angiotensin 2 is a potent vasoconstrictor which acts independently. So that will also vasoconstrict and increase your blood pressure. And aldosterone will increase reabsorption from your kidney, which will give you a little bit more volume. So there's water and salt retention from the kidney. Then other things which happen now, there is vasopressin increased by the posterior pituitary again to act on the kidney to increase water absorption from your collecting duct. Then your adrenals, like we discussed earlier, increase adrenaline and noradrenaline, which will increase your heart rate as well as your peripheral vasoconstriction through circulatory epinephrine and norad. There is increased fluid absorption from the gastrointestinal tract as well as your interstitial spaces. You will feel thirsty and increase appetite for salt, so that will make you behavioral changes to go and look for water and food. There is increased erythropoietin, which will increase your RBC, increase protein synthesis, which will take about 5 6 days, and it will reduce the antinephrotic factor, which will reduce your diuresis again from the kidney. Now, once your hemorrhage moves beyond a certain point, you go into what is called cardiac depression. Okay. So when when you go to cardiac depression, it's due to basically because your coronary blood flow has decreased and your cardiac heart muscle starts becoming ischemic. Your ischemic heart now starts to contract poorly, and therefore it will reduce your cardiac output. And this is the graph you get. If you bleed a patient and do not uterus. So you go into what is called vasoplegia or vasomotor failure. What happens here is the sympathetic nervous system activity will, of course, delay the depression of the arterial pressure. But when your brain's vasomotor center starts becoming ischemic by reduced blood flow, your vasomotor center becomes less active and then finally totally inactive. So if you theoretically, if you cause a circular arrest of the brain, within 4 to 8 minutes, there is intense discharge of sympathetic nervous system because of the hypoxia and the hypercarbia. But after about 10-15 minutes, there is no discharge anymore. The good thing is, if your blood pressure is above 30 millimeters of mercury, usually the vasomotor center continues to work. On the other side of the coin, you have another problem where now you have very thick blood which do not have any forward flow because you are in severe vasoconstricted stage, because you have lost stuff out of the blood vessels, usually in the micro vessels. So you get what is called sludge blood. Now, what will happen here? Your tissue continues to metabolize anaerobically, large amount of acids are generated, and they continue to dump it into the blood vessels. So the sludge blood becomes very acidic. So what will happen there? It will start to clot. So now you have minute blood clots formed. In addition, no new blood flow is coming in, so no nutrients coming in. Therefore, your smooth muscle starts getting now problematic, and your cells in your the capillary cells starts becoming inactivated. So what will happen? You will start getting capillary hypoxia, and then you start leaking. Then you have toxins which are released again by ischemic tissues like endotoxins, histamine, serotonin, all causes. And these endotoxins will also cause cardiac depression. Now, with prolonged Planck vasoconstriction, when the bubble starts producing toxins, they are they are more they also get absorbed and become toxic to the body. One of the biggest problems is, I'm sorry about this slide, something has gone wrong with this slide. There's generalized cellulitis, which is especially the liver. So you have patchy tissue necrosis, acidosis, and depletion of the high energy phosphate substrates. So, in summary, you have hypovolemia, which reduces the blood pressure, which will then activate the baroreceptors or doesn't activate the stress receptors. Therefore, there you have invisible stimulation with vasoconstriction. Then the low pressure receptors are activated in the hypothalamus, which results in increased ADH, which affects the kidney to increase water sodium reabsorption. Then on the other side, it will affect the adrenal cortex, which results in aldosterone. Also, with the renin-angiotensin, you have the adrenal cortex and aldosterone, and the kidney. So then all this increases to water and sodium reabsorption. Right. So let us go back to the first slide I put, hemorrhage. So hemorrhage leads to reduce in blood volume, which will reduce central venous pressure, which that's reduced venous return, reducing cardiac output. So reduction in cardiac output later leads to reduction in mid-arterial pressure, and therefore you have cardio baroreceptors, mechanoreceptors, and the chemoreceptors are now. So then this affects the central nervous system, cardiovascular system, which will inhibit the parasympathetic output and activate the sympathetic output, which will in turn will increase heart rate, increase myocardial contractility, increase venous constriction, and arterial constriction. So increasing heart rate will increase cardiac output, increase myocardial contractility will increase cardiac output, venous constriction will increase cardiac output, arterial constriction will do two things. It will increase total peripheral resistance, and within cardiac output will increase the blood pressure. And in addition, arterial constriction will reduce capillary hydrostatic pressure, increase reabsorption, which will increase cardiac. So we have gone through, I think, virtually everything there is in hemorrhage control. Okay, that is also done. Any questions? Okay, since there are no questions, I will move on to Valsalva maneuver. Right. So basically, the Valsalva maneuver is the cardiovascular responses you get when you blow against a closed glottis. So basically, it's forced expiration against a closed glottis. So how do you do this? You get a person to blow into a mercury column and maintain your airway pressure at about 40 millimeters of mercury and get them to hold it at 10 to 15 seconds. So when you blow out and you hold it, you increase your intrathoracic, your intra-abdominal, and in your intracranial pressures. Your CVP will rise by about 7 to 10 millimeters. Sorry, your CVP rises about 7 millimeters mercury for every 10 millimeter rise in your mouth pressure. And this will lead to a series of cardiovascular changes, which is known as the Valsalva response, which is divided into 4 steps or 4 phases. So this can be graphically depicted like this. So you get your airway, so you of 15 seconds, you get your airway pressure maintained at 40. And this is what will happen to your blood pressure. And this is what will happen to your heart. Okay, so your blood pressure. So let's go through this. So your blood pressure is here, and then you suddenly blow, which causes a rise in the intrathoracic pressure, which will now get transmitted into your arteries. So your blood pressure also now rises. But when you are maintaining a high intrathoracic pressure, what will happen? The gradient between your peripheral vessels and your intrathoracic pressure gradient will reduce. Therefore, your venous return will decrease. So reducing venous return will cause your blood pressure to drop. The drop in pressure will cause compensatory activity, which will now result in what? Narrowing of your blood pressure. But because of other compensating, it will now start slowly increasing. So it will not come back to the same level as which it started with, but it will try to come back somewhere. And when you release this pressure, you lose your sudden intrathoracic pressure, which will cause your blood pressure to suddenly drop. And it will continue to drop. But now your venous return increases. And because your venous return increases, your now blood pressure starts going up and it overshoots. And after overshooting, it will come back to normal. Come back to normal. So in the same way, there is this rapid rise of transmitting of the intrathoracic pressure into the heart or the aorta will result in dropping the heart rate through your baroreceptor reflex. Then dropping pressures will reduce the stretch receptor reflexes. Therefore, you will have increasing vasomotor center, vasomotor center to to increase your heart rate, and it will increase rapidly until your pressure is starting to pick up, and then it will continue to rise some more to get it up to your baseline, and then with the drop in the, it will continue to be high because there is a drop in the pressures here, and then suddenly with the upshoot, it will cause bradycardia and then stabilize back to baseline. Let us go through it again. So the onset of the maneuver, there's a small rise in blood pressure due to the brief fall in the heart rate. This is due to transmission of the intrathoracic pressure onto the aorta. And this intrathoracic pressure forces blood out of the pulmonary circulation. I didn't mention this. So the intrathoracic pressure rise will push the pulmonary blood back into the left atrium, which will in turn will increase left ventricular stroke volume. In phase 2, the continued increase in intrathoracic pressure will decrease the venous return to the heart, right side, which will then, your venous return equals your cardiac output. So therefore, there is a reduction in your cardiac output, which will result in the blood pressure, fall in the blood pressure, which then stimulates baroreceptors, or well, in sense, it doesn't stretch, so there's less stimulation, and therefore there's increased sympathetic output, which will increase your heart rate and peripheral vasoconstriction to restore your blood pressure. Immediately after the release of the positive airway pressure is phase 3. There is loss of pressure on the aorta and re-expansion of the pulmonary vessels, which will cause a small fall in the stroke volume, the transient fall in the blood pressure, and further rise in the heart rate. Then, with the intrathoracic pressure at baseline, your venous return is normalized, which will normalize your cardiac output, but you still have vasoconstricted vascular bed, which will overshoot your blood pressures, which will then be sensed by the baroreceptors, which will then reduce your sympathetic output and increase your parasympathetic output, which will result in bradycardia and reduction in the systemic esterase resistance, which will then cause your blood pressure back to normal. Okay? It's tricky. That's how I do it. Right. So what are the abnormal responses? So if you have diminished baroreceptor reflex, like in patients with diabetic autoneuropathy or quadriplegic patients, what will happen? So they will, because you don't have the baroreceptor, if you have reflex, they are unable to maintain your blood pressure. So your reduction in venous return will not be compensated by increasing contractility of the heart as well as the heart rate. Therefore, you start dropping your pressures. And then once your venous return is restored, you come back to normal. So there is excessive fall in blood pressure in phase 2 and absence of overshoot and bradycardia in phase 4. There's no bradycardia and no overshoot. So you simply drop your pressures, and once this thing is gone, you come back to normal. If you have congestive cardiac failure, you have what's called a square wave response. So what happens here is basically your blood pressure remains elevated throughout phase 2. Okay. And then in phase 4, there is no overshoot. There's very little change in heart rate because you are now fluid overloaded. So the increased blood volume and raised peripheral venous pressure maintain venous return. So because you have increased blood volume and increased peripheral venous pressure, you maintain the venous return to the heart and the cardiac output. So basically what happens is the intrathoracic pressure which is transferred onto the aorta remains. And when you take it out, you come back to normal. We use the Valsalva maneuver to assess autonomic function to ensure that the systemic nervous system is working, and also in SVTs to slow down the heart rate. So bedside methods of doing this is to take ECG and do longest RR interval and divide by the shortest RR interval in phase 4. And if the ratio is normally more than 1.5, your function is normal. If it's less than 1.5, it is impaired. This is known as the Valsalva ratio. Okay. We have come to the end of our talk. Are there any questions? If you are shy to talk, you can type in the chat box. Nothing. Hmm. Oh, what bunch of people you are. Okay. Thank you very much for joining in. I hope you gained something from my talk. Somebody has a message at last. That person is thanking. Thank you. You are most welcome. Thank you for joining. I hope you had some input, and I wish you all the best for the exams. And basically, have a good weekend. Well, you have a few hours left, so I hope you have a fabulous few hours. Okay, guys, have a good evening and the best of luck to you all.